First speaker is Mr. Alexander Mearns, come from Scotland. This afternoon, he will talk about a comparison of case studies in the treatment of carpal tunnel syndrome, TCM acupuncture versus FSN acupuncture. Let me simply introduce Mr. Alexander Mearns. He has got the BSc degree currently. Alexander currently works as Vice President of ATCM. He has practiced in Scotland, used both TCM and FSN for a variety of conditions. He graduated from College of Chinese Medicine and Acupuncture in Reading in the UK. He is also the English language editor for ATCM's journal. In 2019, he became a member of the Europe FSN Association and became a member for FSN on the World Federation of Chinese Medicine Societies. He has published a number of papers on TCM and FSN treatments. He has recently co-authored the first English language manual for FSN. So he is brilliant. So let's warmly welcome Alexander for his presentation for 25 minutes. So please, Alexander.
Yes, thank you very much, Dr. Nia. Now I'll just get the share screen set up properly.
Okay.
And see if I can switch it to cover the whole screen.
Yeah.
Ooh, whoops, didn't mean to do that.
File full screen.
Yeah, slideshow, there we go. Start from the beginning. There we go. Perfect. I can just move the FSN, the Zoom bit to the side. Right, so as we were saying, what I'd like to present to you today is a comparison of case studies with the treatment of carpal tunnel syndrome, something I've done quite a bit over a number of years. I don't know that I'll be quite all 25 minutes, you'll be pleased to hear, but I hope you find it interesting. Now, carpal tunnel syndrome occurs when the medial nerve is compressed at the wrist under the transverse carpal ligament. It's a very, very common form of nerve entrapment, and estimates of at least 7 to 16% of sufferers in the UK. And you can see that a general practice research database found that for 100,000 of the population, 88 men and 193 women presented. Western medical treatment involves just simply leaving it alone to rest, putting a splint on it, anti-inflammatories, usually some physiotherapy, and as a final step, surgery, which it is claimed a 90% success rate. I would question that figure, but that's a topic for another talk, I suppose. Because yes, once you've cut the transverse carpal ligament, it's going to feel better, but there's lots of other problems. So I'm not quite sure that that would be a success. However, so as you can see in the picture here, the median nerve runs underneath this piece that crosses the wrist. And that's what compresses the problem, resulting in the nerve pain. And I think we got an excellent explanation of nerve pain of various kinds from our previous speaker, Dr. Wang. And you can see also in the picture that the defining diagnostic feature is the thumb, the first, second, and third fingers are the ones that are affected. And here's a view of the surgery, which actually severs the transverse carpal ligament. Kind of severe, actually, but there you go. That's what's done. And it's not something that you can, if it doesn't work, it's not something you can not do, because you've cut the thing, it's broken. So if people can avoid that, that would be a good step. Now, with respect to traditional acupuncture, you can put carpal tunnel syndrome into involving three patterns: a blood vacuity not nourishing the sinews and vessels, T stagnation, or chi stagnation, I should say, and blood stasis, and a wind damp impediment. And looking at the people that I've seen over the years, there's usually a combination of all of those, and where the emphasis lies is going to be on the individual. But those are the things to look at. And I've published a study back in 2014, and I also noticed that spleen vacuity was an important underlying pattern. And then along with some local heat, the heat probably from the stagnation of chi. And the success was quite good. You know, looking at 5 cases, of course, carpal tunnel syndrome was resolved for 3 of the patients after just 3 treatments, for which they were very grateful. And 1 patient had 4 treatments. And another patient estimated perhaps a 40% improvement after 3 treatments. And the main points used locally were LI4, pericardium 6, and PC7. And then, of course, to address the larger picture, you would use whatever points were required individually according to the pattern diagnosis. And as I said, people were very pleased. I was pleased as well. And a number of people avoided surgery. Remember, one individual, not in this particular case study here, was from Australia and just was visiting, and he was facing going back for a double carpal tunnel syndrome surgery. And as far as I'm aware, he was able to avoid both of them. So TCM certainly did the job there. However, since that study, which was back in 2014, I trained in a modern form of acupuncture, as becoming well known now, FSN, or Fu's subcutaneous needling. Although I much prefer the floating needle name in Mandarin. It's much more poetic and just kind of nice, not so technical. And the results have been very, very encouraging. And with regard to pain problems, I would say that it resolves complaints much, much quicker than traditional Chinese medicine acupuncture. So I decided to have a look back over my notes and audit the carpal tunnel syndrome conditions which were treated with FSN acupuncture to see if, as a group, there was any advantage to FSN acupuncture as opposed to TCM acupuncture. So in order to compare the same number of cases, I chose 5, and all of those people had a diagnosis of carpal tunnel syndrome from their GP. That was also the case in the 2014 study. Now, a wee introduction to FSN. It was developed quite recently in Nanjing, as you can see, in the 1990s. And it involves quite a different kind of acupuncture needle. And there's a manipulation involved and also a tightening of the muscles. So interestingly, the FSN needle inserts sideways into the subcutaneous layer, the layers between the skin and the muscle. So it's almost pain-free, but there's a wee nip at the beginning. And because it's so very, very shallow, where people go wrong in their needling and cause pain, it's mostly because it's not shallow enough. So sideways needling, very shallow, and it's been found that it can relieve pain very, very effectively. Here's a picture of the needle. It was developed especially by Dr. Fu, and you don't necessarily have to have it, but it's a lot easier if you use the application device, because it limits the depth of the needle and it's very, very quick, therefore reducing the pain. But I have seen practitioners insert the needle effortlessly or painlessly without using the applicator. Interestingly, you don't needle where the pain is. You needle a distance away from the pain. And sometimes in a technique with a phrase I don't like called remote bombing, you might, for example, treat the forearm in order to have an effect, I should say, in the muscles perhaps of the shoulder. That was an interesting discussion when we were authoring the book, because not being very militaristically inclined, I was using remote effect, but it was written out by Dr. Fu, who used the equivalent term in Chinese, which is remote bombing. And I understand it's a cultural difference, that the military is highly, highly, highly respected and such like. So he was the boss, so the book says remote bombing, but my own preference would have been remote effect. So it's not actually in where the pain is. It's a distance away from where the pain is. Now, in order, diagnosis is not based on syndrome diagnosis, or it's not based on 5-element diagnosis or anything like that. It's based on surface anatomy. So noting where the problem is, the practitioner will palpate for tightened muscles. And something I do probably more often than, well, with more confidence than the palpitation, is to conduct muscle tests to determine which muscles need treatment. There's various things, physiotherapy textbooks are extremely good for this, that show certain movements are related directly to certain muscles. So by determining which of the movements are impeded, then you'll have a very good idea of which of muscles need treatment. Palpitation is very, very good, yes, but don't forget there's layer on top of layer on top of layer of muscles. And sometimes I'm not convinced that palpitation is really telling you what the muscles underneath are doing. But if you move the limb or move the part that's in trouble, then you can be very specific about what needs to be done. So once you've decided on which muscles need to be treated, then you choose an insertion point outside of the tightened area. And then, as we were saying, you insert the needle with the applicator, insert sideways into the subcutaneous needle, and then it's moved from side to side. I don't know if you can see in this little wee picture, if this was just a pen here, you just sort of do it like that, at about that speed actually. And that's referred to as the swaying movement. In addition, it's been found that the technique works far better if the relevant tight muscle is flexed against resistance provided by the practitioner. So you get the patient to over tighten the affected muscle. And that process is referred to as reperfusion, which just means a reinvigoration of blood into the area. So I suppose in terms of TCM, what we're talking about here is moving stagnant chi and moving the blood. Now, we've just had a nice elucidation of the mechanisms of FSN by Professor Wang, but as he says, we're not particularly sure about the mechanism, and it may involve the fascia layers, it may involve the dendritic network that Dr. Wang was talking about. And of course, there's also that recently there was the discovery of the interstitium, which is related to the fascia areas, and there is a small amount of liquid in the interstitium, which connects the body all together. And once, of course, you've got liquid, then you've got chance of cellular communication. So it may be one or all of these kind of mechanisms that are operating. So a lot more research would be necessary to work that out. But from the point of view of a clinician, you see, does it work or does it not? Okay, now we really have to be aware of surface anatomy, not meridians and points and all of this kind of thing. So with regard to carpal tunnel syndrome, here's the surface anatomy of the ventral part of the arm. And you can see the surface muscles, at least, the two most common that I've had to deal with are the brachioradialis and the flexor carpi radialis. However, it's always good to check the muscles that are distal to where the problem is. So you might want to look at the biceps, deltoid, or triceps as well. The patient will be a good guide to that, plus basic palpation skills. So by muscle testing or palpation, then you'll be able to decide which is the tight muscle, and then you choose a point outside of the tightness. And sometimes that's sort of awkward with carpal tunnel syndrome because you're working around the knee and you've got to get the needle in kind of flat, so it can be awkward, but ways around it. And then you follow the procedure as described. So with regard to case studies, one interesting one was a dentist, 40 years old, and she had carpal tunnel syndrome in both her hands. And you can imagine for someone who's working as a dentist, just how difficult work would be, not to mention life in general, with both of your hands aren't working optimally. So looking for tightness is found in the flexor carpi radialis on both arms. And I'll just go back and you can see where that is. And so an insertion point was chosen towards the proximal end of the muscle. That means near the elbow, of course, but it was trying to leave sufficient room for needle manipulation. And reperfusion, I tend to do it quite widely. She can either squeeze my hand and also turn the arm in and out. Then after that, you find out whether the person is feeling better or not, and then choose another point, which was closer to the wrist this time. And then after that, as you can see, the patient said she felt relieved just about 100%. And I didn't need to see her again. And I'm hoping it's not because she just didn't come back. Another one, similar, and this was another woman, 46 years old, and an electrician. And again, both of her hands were causing a problem, which made work very, very difficult, and no doubt aggravated and caused by her work as an electrician. Now she had, first treatment at least, tight muscles were located once again on the flexor carpi radialis and also on the brachioradialis. And an insertion point was chosen as before in the proximal end of these muscles, and her pain disappeared very, very quickly during reperfusion. And because both hands were a problem and they were both similar, she was treated bilaterally. Now, after 3 years, she came for another treatment, and very similar treatment, flexor carpi radialis, brachioradialis, were treated as before. Now, in addition, she had also topical from today, she had a shoulder problem, so the supraspinatus, that's the one that's just above that ridge in your scapula, that was also treated. Sometimes also, or quite often I should say, with FSN, you treat a person and then you leave them for 10 minutes or so, and then perhaps treat again. The reason being that quite often you relax the muscle, person's feeling better, but then the muscles just tighten up again. If that happens, it'll happen fairly quickly, and it doesn't take very much additional needling to relax the muscles again. So it's good to leave someone for a rest period and then recheck. The needle also has a plastic casing on it. And one thing you can do is you can remove the metal part of the needle, but leave the plastic casing still in the subcutaneous region under the skin for a couple of hours, maybe till the next day. In a sense, it copies what you do in treatment. In treatment, the practitioner is moving the needle around and you're over tightening the muscle. When the casing is left in, the person just moving around by themselves is moving the casing to a degree, and also the muscle movement is like tightening the muscles. So it extends the treatment. So that's something that many people do. I tend not to, if the person is right away better, which is frequently the case, I tend not to. And also you have to decide who's the patient you've got. If you've got someone who's a nurse or can reach it to take it out later on themselves, not particularly afraid of taking medical things out of their skin, that's fine. But a number of people aren't. It might be a shoulder problem and they won't be able to reach the casing. They may be kind of a nervous person, so you don't want to do that. So there's reasons you might not want to, but it's an option that one can do if you like. Case 3, another woman, 32 years old and an accountant, and the typing was her problem. And in this case, brachioradialis, flexor carpi radialis again, and rest period, went back and retreated one side. And in addition, I also treated her lower back because she had that problem as well. And I saw her next week and she didn't need any extra treatment, but she did have a sore shoulder, which is probably what took her back. So I treated that. Case 4, I was going to say an elderly woman, but I'm not that far off it myself. So she had some carpal tunnel syndrome on her right side, and it had been a problem over a year. So same muscles as the other ones, both were tight, both were treated, and fortunately she had an immediate improvement. She came back again, but she was nearly problem-free. It hadn't completely gone away. And a year and a half from the time of writing, which was maybe a year ago, she hasn't had to come back for treatment. So once again, happy to say very successful. Case 5, just one side this time, carpal tunnel syndrome in her right hand for several years, and she had to put up with it. But after having fallen and breaking both her arms, can you imagine that? The carpal tunnel syndrome returned much, much worse. So she decided to look into getting treatment for it. In this case, as I said earlier, it's an example of looking beyond simply the carpal tunnel syndrome to look at the muscles which are connecting up. And in this case, the right bicep was very tight, as well as the brachioradialis, flexor carpi radialis. So all of those were treated. And in her case, forget why, I think she might have been a nurse. I left the case in and there was a nice improvement. Treatment 2, she thought that the treatment was very, very good, but there was still a slight tingling in her thumb and the next 2 fingers, which of course is of diagnostic significance with carpal tunnel syndrome. So retreated, and that seems to have done the trick for her. So looking back at the TCM approach and the FSN approach, the TCM approach was very successful. Most patients were relieved of their carpal tunnel problem with 3 treatments and 1 retrieve 4 treatments. The odd time there's somebody you just can't help. I remember one person, and the problem was not that the treatment didn't work, but it just kept coming back because he worked in a factory and he used some particular kind of a machine that vibrated and cut things. And just holding onto the machine and working with it kept bringing the carpal tunnel syndrome back. So he was sort of in a difficult position because he couldn't not do his work, but he couldn't get rid of his carpal tunnel syndrome. So it wasn't that the TCM didn't work, it was just the situation, unfortunately, was unresolvable at that point. Now, when you look at the FSN approach, 2 of the 5 patients appeared to have satisfactory results after just 1 treatment, not 3. And the other 3 of the 5 received 2 treatments. So in this cohort of people that I looked at, it looked like the FSN approach works more quickly than TCM, and in fact, cut the amount of treatments necessary actually in half. So for that reason, with carpal tunnel syndrome, that's the first thing I would think of doing. Now, from time to time, I combine it with TCM. If someone has, you take pulses, for example, and you see that there's a spleen deficiency, liver cheese stagnation, well, I'll treat those things as well for the general well-being and just to give the person a boost. And I was trained in Reading, as I think Dr. Mia had pointed out, which is the 5-element approach as well. So I might even do a tonification of an element just to give them a boost if I think they're needing it. But specific to carpal tunnel syndrome itself, the FSN approach works extremely well. And there's some references, and that's really all I have to say on the topic. So in summary, it looks as if the FSN treatment for carpal tunnel syndrome reduces treatments to 1, possibly 2, instead of 3, possibly 4. And that's quite a benefit for the patient. So thank you very much.